and let's be in a relaxed mode. We are just going to refresh about MRCOG Part 3 exam and a few tips here and there as to what exactly is expected. So this session is particularly for those who are just newly answering MRCOG Part 3. You may be attempting in November or later in May. So how this exam is different from the previous exams that we've answered, which is the MRCOG Part 1, which was theory, and the Part 2 as well was theory exam. All right. So now let's look at uh, the finer points or the important things that we need to note when we are preparing for the MRCOG Part 3 exam. So let's begin. All right. So what we are going to look at is basically we need to understand the structure and the purpose of the MRCOG Part 3 exam. So that's important for us to know because our preparation for the exam would depend on how the exam is conducted. Okay. We need to familiarize with the exam format and the marking scheme and domains, and we need to have a strategic approach to preparation. All right. The core competencies expected we would need to know and recognize certain common pitfalls and success strategies that we would be discussing. All right. So what exactly is MRCOG Part 3 exam? As we know, this is a clinical assessment of knowledge, skills, attitudes, and competencies. Okay, so it would be once you pass the exam, you would get the degree, which is granted by the Royal College of Obstetricians and Gynecology. And that would give you your entry point to your maybe a residency in the UK and certain other countries as well. What is the format? Okay, just to brush through the quickly, what is the format of the MRCOG Part 3 exam? As you must have read or you must be familiar, and for those who have answered the exam previously, you would know that we have 14 tasks. And these 14 tasks are based on 14 modules. Like you have the early pregnancy module, you have the antenatal module, antenatal care module, you have maternal medicine module, then you have general gynecology, oncology, urogynecology, so on and so forth. Okay, such 14 modules you would have in the exam, and there would be one task per module. Remember, clinical governance is not a separate module. That's something that we need to know because a lot of candidates do ask us, okay, what about the clinical governance? Isn't that a separate module? What stations do you get on clinical governance? No, you don't get a separate task on clinical governance, but clinical governance is important in all the tasks, wherever applicable. So that's something that we need to know. So what does a circuit look like for those who are not familiar? A circuit looks like this. So there would be the invigilator who is sitting at the center, the supervisor for the exam, and there would be 14 candidates that are moving from one cubicle to the other cubicle and so on and so forth. There are 14 such cubicles. Okay, so that is how the exam would be conducted, and you know that you have 2 minutes time for you to read the task, and yeah, 2 minutes time for you to read the task and 10 minutes for you to do the task. Okay, so can you see there is a white paper which is stuck on the, can you see this? There is a white paper which is stuck outside the door of each of the cubicles. That is where your question would be in the exam. So when you are going from one cubicle to the other, say you are going from cubicle number 4 to cubicle number 5, on the door would be this particular paper that's stuck, which is the question of the concerned question. Okay, so that is the task that you are supposed to do. Also, when you enter the cubicle, the task would be stuck on the table as well, and you would not get to see the time. Okay, the time would be just based on the buzzer that they would ring at 2 minutes and 10 minutes. So don't think that you will get to see how much time is left in the task. You would not get to see the time left in the task. So it is just the buzzer that they would ring. And that is why it is so important, and we emphasize in our courses as well, that you need to put your biological clock on. So you need to know that, okay, I think I have finished my history by 4 minutes. That is how good your practice should be. You should know that, okay, I have managed to finish my history by 4 minutes. I have managed to finish my history taking by 3 minutes. Now the rest of the time I can spend on management plan. So that is how you need to practice. You need to train your biological clock to know where in the station you are. So if you think that you're running out of time, you have gone slow in the task, you know that you have to finish off by saying the important points that would fetch you the necessary points. Okay. And if you think you have done well and you've finished your history taking in time, you can do in a relaxed fashion the rest of the task. Okay, provided you have read the task well. All right. So this is how a circuit in the MRCOG Part 3 exam would look. Then, so what are the tasks that we get? And it is important to note, we have candidates that perform in sessions that we have for courses. It would be written at the top. This is a simulated patient task, or it would be written at the top. This is a structured discussion. Okay. And there is a way you start your simulated patient's task, and there is a way you start your structured discussions, obviously, because in a simulated patient task, you are talking to the patient. While in a structured discussion, it is like a viva. You're answering the questions that are asked by the examiner. So in a simulated patient task, you have to start by confirming the identity of the patient. So you need to say that I am so and so, I'm one of the doctors in the clinic here. Am I speaking with so and so? Or may I confirm your name, please? Okay, so that is confirming identity, and that is essential to start with. So do have a particular way in which you start your tasks and practice in that manner so that there is no confusion in the exam. Do not keep changing the way you approach the task unless it is a sensitive task. For example, if it's a young girl who has been raped, then you will not start the same way. You're going to say, hi, I'm, in a low tone with a lot of empathy. You're going to say that, hi, I'm so and so. I'm one of the doctors here. I'm here to help you. I'm aware of your situation. Am I talking to so and so? Okay. So that is how you would start your simulated patient task depending on the situation. So have a set introductory question that in your mind that you would do for general tasks, and for certain sensitive tasks or tasks where the patient is having a complaint and she's restless or breathless or she's in pain, you need to change the way you introduce. You could say, hi, I'm so and so, I'm one of the doctors in the hospital today, I'm here to help you. Am I talking to so and so? I can see that you are in pain. All right, so that is how you would do the task. All right. Now, remember, all of us know about simulated patient tasks, and all of us know about structured discussions, right? So simulated patient task is where you talk to a patient. Structured discussion is where you have an examiner sitting in front of you, and that is going to be a viva. Okay. There are simulated colleague tasks as well, which is a teaching task. So you are about to see your colleague, which is say your ST1, your ST2, and who wants to learn about forceps delivery, and you are supposed to demonstrate forceps to that particular colleague. Okay, so that is how the station would be. Okay, so that would be a simulated colleague task. So you need to read what task it is. Similarly, sometimes, and this is a very, very common mistake done by most candidates, sometimes even in a labor ward station where you have a list given to you of labor rooms, and each room will have a description about a particular patient. So there will be a list of rooms that is mentioned there with the description. Uh, and it would be sometimes given to you as a structured discussion, wherein you need to go in and talk to the examiner what you're going to do in each of these rooms. Sometimes it may be a simulated colleague task, wherein it is mentioned to you that you are about to see the midwife. and the senior midwife, for example, who's the coordinator usually in the labor ward. So the senior midwife, you are about to see the senior midwife. This is a simulated colleague task, and you're supposed to be discussing the management of all the rooms with her. So that the way you start a simulated colleague task will also be different from a structured discussion. For example, if it's the midwife task, then you would start by saying, I am the ST5 posted on the labor ward today, because you're in the simulated situation. You have to act out the situation. I am posted here on the labor ward. I believe you are the senior midwife, and can we go through the labor board and discuss the management plan? On the other hand, if it is given to you that it is a structured discussion, you will start like you start all your structured discussions. You would say, I am so and so, I am one of the candidates for the MRCOG Part 3 exam. I'm ready for the structured discussion. So you need to be very sure what kind of task you're dealing with. Very rarely, and this is not seen often, you can get linked tasks. That means task number 4, for example, is a structured discussion about, say, ectopic pregnancy, ruptured ectopic pregnancy. And then task 5 would be a link station to that particular station. Maybe it would be about writing discharge summary of ectopic pregnancy, which was station number 4. Okay, so those are linked station, nothing different, but you may get a linked task and you may get confused in the exam because this is there in the website of the RCOG that there could be certain linked tasks. So one task is linked to the other. So one task follows the other. So that is how you would have your task. So you have, once again, you have simulated patient tasks, you have simulated colleague tasks, and you have structured discussion. So this is something that you really need to look into when you're starting the reading part of the task. All right. So this is how the task would appear. All right. So this is the candidate here. This is the patient here. And this is the examiner. So get the good feel of the exam cubicle. This is how an exam cubicle would appear. All right. So why am I telling you this? Because sometimes if you're answering it for the first time, you may, you may get confused, and it's important to familiarize with the tasks. I mean, to familiarize with the situation there in the exam hall. Okay. So this is one cubicle, which we had seen earlier. There are all those 14 cubicles arranged one after the other. So this is one such cubicle. And can you see on the table, there is the exam question which is attached. So for you to read. So do not worry, there would be a question which is attached to the table. Okay. And remember, the examiner would generally not be talking at all in a simulated patient task. So do not look at the examiner to see whether she's giving any particular, she's making faces, he or she's making faces, or she's trying to give you clues, or has she passed you, has she not passed you? No, she's not going to give you any reaction. So there is no point looking at the examiner while you're performing your task. You need to just focus on your patient. Okay. So the examiner only talks in your structured discussions. Okay. There would also be lay examiners. So sometimes there would be 2 people sitting in the tasks. Out of 14 tasks, you would have at least 4 tasks with a lay examiner. That means that particular examiner is not from the medical field. Okay. So there are 2 examiners in that particular task. Okay. And that means that particular task which has lay examiner has maximum weightage because marks are allotted to you by not just the clinical examiner, also by the lay examiner. Okay. So that is how your marks would be doubled. Okay. The applied clinical knowledge is the only domain that the lay examiner will not mark you on. Rest of the domains the lay examiner will mark you on. Okay. What is lay examiner? He can be from any other field. He's just sitting there. He's watching you, how you approach a particular patient situation. How are you talking to the patient? How do you deal with a situation that is put to you? Okay, so these are the things that the lay examiner is assessing. So 4 out of 14 tasks. So you need to be more careful about these tasks simply because they have more weightage. And which task would be the ones with lay examiner? Typically something like a breaking bad news. All right. So, or making a management plan in, say, maternal medicine module stations, usually, where you have to talk about the entire pregnancy course with in the light of she having the medical disease. So, such tasks would be the ones that may have more weightage because there would be a lay examiner. Okay, so here in this picture, you can see there is just one examiner and she's busy marking you while you are performing the task. So as you are saying the points, she's checking in her examiner list. They would be having all the domains. The exam goes domain wise. Remember that we will be coming to that. So they will have all the domains there with all the points necessary that are required to be said in those domains, and they just check if okay, this is said, this she said, how she's communication, she's done the empathy, she's breaking bad news is done properly, all of such points. Has she used any medical jargons? So this is how they will mark you on each of those domains, and that is why the score that you get, the score that you obtain in the exam is domain wise. So basically, they will tell you that you have reached the expected standard in this particular domain, information gathering. In second domain, communication, you have not reached expected standard. So that is how the marking goes. All right. So you have to pass in all domains. Remember that. Now, yeah, so these are the 5 domains that we have in the MRCOG Part 3 exam. Patient safety, communication with patient and their relatives, communication with colleague, and this is assessed in teaching tasks. It is also assessed in structured discussions. Okay. Information gathering, applied clinical knowledge. Okay. Patient safety basically describes how safe you are as an ST5 for that particular situation. Whether you are making a safe plan for her, whether you're telling her things that are meant for her safety. Okay. Communication with the patient is also important, and we will be discussing that in detail. Of course, we have in our on our Excel channel, we have detailed videos on each of the domains. So I could share them with you on the group later. So I'm just giving you an overview of what the exam is about. Okay. So communication with patient, communication with colleague is a very important domain to note in the exam. Put an asterisk there. If you're making notes, make an asterisk that communication with colleague is an important domain. Why? Because there are hardly any points that you would need to say to get a full score in communication with colleague. What it assesses is how you talk to the examiner. Like, as I told you, in a structured discussion, you would be assessed for communication with colleague. You would not be assessed for communication with colleague in a simulated patient task because you're talking to the patient. There, it would be communication with the patient. In a structured discussion, you will have communication with colleagues. So it assesses how you are talking to the examiner. That's one. Which other specialties, or like, for example, whenever there is a MDT need for involving a multidisciplinary team for management of a particular patient. So whether you say it in the exam, MDT, that would be counted in communication with colleague. Say when there is a Down screening positive patient, high risk for Downs, has come to you, and you say that we would need to refer this patient to a fetal medicine specialist. Saying fetal medicine specialist gives you the points necessary in communication with colleague. So just a few things. Naming the colleagues that would be involved in the management. Not if it is an MDT, you can just say the team of doctors or the MDT. So saying those things will fetch you the necessary points that are needed in communication with colleagues. So please don't lose marks on communication with colleague, because it is very easy to score on communication with colleague. At the same time, I would say it is very easy to lose on communication with colleague in case you forget to say MDT in your entire task, say on hemophilia or von Willebrand disease in pregnancy. You forget to say MDT. Okay, it's a structured discussion on von Willebrand disease in pregnancy, and you have not mentioned involving the hematologist, the blood bank, the consultant, etc., etc., in your care. You will lose completely on communication with colleague. Just a single sentence would have helped, right? So that is why pay attention, special attention to this particular domain of communication with colleague. Information gathering is also quite easy. We will be discussing that. And applied clinical knowledge is absolutely the clinical knowledge about that particular topic that you have that you need to discuss in the task. All right. So these are the domains. So whenever there is a task like this task, for example, this is a simulated patient task. It is written on top, simulated patient task. It may not be written on top the way it is written here. It may be just written in a simple line that this is a simulated patient task. Okay. And it will be written, the task assesses the following four domains. One is information gathering, communication with patients, patient safety, applied clinical knowledge. These are the four domains in this particular task that you are supposed to be marked on. Okay. Now the body of the task. Okay. So this would be the body of the task. That means here you will get all your information that you would need to do the task. Okay. And here will be the description of what you are expected to do in the task. Okay. So in this case, they have said your task is to explain the need for an instrumental delivery, ascertain her views, explore her concerns, and provide guidance for a safe outcome. Okay. So that means you know that she has certain concerns, she has her own views, and you need to explain to her about instrumentation. That is what you need to understand. Okay, the situation here, if you can notice, if you can see, you are about to review Mrs. Lucy, who has been pushing at full dilatation for over 2 hours with no obvious progress despite intravenous syntocinon. Labor was spontaneous and the first stage has been uneventful with good progress. By now, Mrs. Duncan is absolutely exhausted, although there is no fetal distress. So now here you know it's been 2 hours, she's exhausted. Indication of an instrumental delivery would be that she's exhausted. Okay. The fetal head is not palpable on abdominal examination. That tells you that she is a candidate for instrumentation because her head is not palpable abdominally. That means her head is engaged completely in. That is one of the prerequisites. Vaginal examination shows that there is full dilatation and the head is at +3 station with left occipito anterior position. What does that mean? That means that again she is a good candidate for instrumentation and there is a mild caput and no molding. So this situation assessment of this is what you need to know when you are is what you need to interpret when a particular situation is given, and that is situational awareness. You must be able to interpret the information that is given to you and apply your knowledge from forceps delivery, whether instrumental delivery would be applicable in this case or not. If it is applicable in this case, then you're going to tell her about the instrumental delivery. So now what has been given to you is that the midwife has asked you to help to deliver the baby as the head is not low enough to be delivered solely with the help of an episiotomy. So you know that you need to apply an instrument. So, and remember this is a simulated patient task. So you need to go in. Imagine this is the labor room. The imagining part is important, that you need to imagine that you're going into the labor room. This is a patient in second stage. This is an exhausted patient. So you need to go there. You say that, hi, I'm so and so. I'm one of the doctors here. I believe you are Mrs. Lucy, and the midwife has summoned me to help you. I can see that you've been doing quite well. You've been pushing for the past 2 hours, and I'm here to guide you. So if you say in this manner, what happens is the examiner knows that you are aware of the situation that you are put in. You are put in this labor ward where this particular lady is exhausted and she's pushing. Okay. So you are acknowledging the flat fact that she's tired, she's pushing for such a long time, and that you are here to help her. Okay. So that itself gives a good intro. Okay. So this is a special situation where your intro for the task would differ a little bit. But then again, you know that information gathering is a domain. Check the domains, right? Information gathering is a domain. That means you have to take history from her. So you can say that I know that you've been doing quite well and I'm here to guide you, but is it okay to know you better? I would like to ask you a couple of questions. So once you say that, the patient is going to say yes because that is what they are instructed to do, the role player. And then you ask only specific questions. In second stage of labor, don't ask her family history, please. Don't ask her the LMP. Very few questions. In labor, you just ask, how has the pregnancy been so far? So when did you have your labor pains? And are you feeling all right? How is the pain relief? What pain relief measures? Is there any drip that is given to her? Those things are important. And medical diseases, previous surgeries, allergies are important, BMI, blood group, any reservation to transfusion. These are the only things that you would need in labor. And of course, asking about the birthing partner, whether her partner is with her. That is all that is important. Do not ask for smoking in labor, please. She's in second stage of labor. Do not ask for family history. Do not ask when her LMP was. So, relevant history. It's very important to stick to relevance. Okay, so whatever you think is important and you would need to know is what you need to ask. Okay, so if of course if there is a previous pregnancy, you need to ask the previous pregnancy history as well, because that how she delivered in the previous pregnancy does have a bearing on current pregnancy. So that is why it is important. Okay, so be smart in practicing these tasks, and when you have the labor module that is assessed, you need to stick to just the adequate number of questions in the history. Of course, if the patient is in early labor and she's comfortable, then you can go on and ask about how the scans were and all, how the baby movements are, etc., etc. But not in the second stage of labor when it is mentioned that the patient is exhausted. All right, so that is how you would do your task. So this is your simulated patient task, and this is how it appears in the exam, exactly like this. All right, so this is the clinical examiner's instructions. So what the examiner will have to assess is given in the form of instructions. So what is given to the examiner is this: the competent candidate. Now, this is in reference to the task we just discussed. All right. So, a competent candidate will establish parity. We need that, whether she's nullipara or whether she's multipara. Okay. The reason for expediting delivery, prolonged second stage with maternal exhaustion, and identify the patient's wishes and concerns. So, you need to know what the patient wants. Patient may say, just say, it may be a negotiation task. Patient may say, I know I want to deliver normally. I don't want an instrument. I don't want an instrument. See, whenever the patient is making an irrational demand, so this is irrational. You are trying to help her, but she's trying to tell you, no, I'm fine. I'll do it on my own. So if the patient is stubborn, patient is telling you something that contradicts your medical or your clinical opinion, the first thing that you need to do is you need to ask her why. Okay, why does she not want to have an instrumentation done? That's the first thing. She may be having some concern, some fear about instrumental delivery. You need to explore that area. That's the first thing that you need to do. Okay, is there any specific reason why do you say so? Why do you not want to have an instrumental delivery? Nicely, calmly. Okay, that is how you ask. Okay, then you tell her the possibilities that would happen if she doesn't let you apply instrument. You need to tell her that the worst thing that can happen to her and the baby. You need to tell her. Otherwise, she may say, no, no, no. So what? I'll just push. If you just say over here, if you don't deliver by this time, then you will get exhausted. If that is all that you have to say, okay? She may not cooperate. Okay? So what do you think you would say to her? Anyone can tell me, anyone can message in the chat box, or even you can um, unmute yourself and tell me what do you think you should be telling her in this particular task. Anybody? Why are you doing an instrumental delivery? So how are you going to explain that to her? She's pushing for 2 hours, she's exhausted. So what? And she doesn't want an instrumentation done. Okay, so how would you say it? You can put it in the chat box. No worries. Anybody? Come on. It's pretty simple. Why do you think you do? Yes. Yes, doctor.
That is a chance for maternal and fetal compromise, ma'am. The maternal exhaustion can actually aggravate a fetal compromise. So we'll have to reinforce her on that angle.
Yes, that is true. That is true. That we need to tell her that if you continue pushing, then you would get exhausted. Okay, you need not say that you are exhausted because that she may not like it when you tell her that you are exhausted. Okay, so you say that you could get exhausted. Okay, your baby in the womb may not be happy. Okay, we need to check that we need to check the baby's heart. The baby in the womb may not be happy, may be stressed out. Okay, use lay language. Okay, so you're talking about distress in the baby. You also tell her that if she's priming, if she's nulli para, you need to tell her that if she continues pushing, the womb can stop contracting. Okay, you may not progress any further, and even if we try to deliver you later, the womb may not contract enough, and that can result in bleeding because it goes in inertia. Primies go in inertia, multis go in obstructed labor. Remember that. Okay, so your womb can get exhausted too and can have it may not progress any further, and even if we try to deliver you, the womb may not contract after your delivery and you can have bleeding which can be life threatening. So use words like this: life threatening, bleeding. Okay, because those are facts. PPH is life threatening. Okay, that's one thing. About the baby, you need to tell her in a very sensitive manner that if the baby, we find that the baby is not doing well, baby is stressed out, there is a possibility that the baby may suffer permanent damage or even die. See how I'm changing my tone? That is how you need to talk. Okay, I'm really sorry to be saying this. But if we do not act now, if we do not help you with an instrumentation now, then there is a chance that the baby may suffer permanent damage or may even die. Okay. Of course, you also have to discuss some other things. Like what else would you tell her in this case? Anybody? Sorry?
Ma'am, she prolongs second stage also, no? There are chances of postpartum hemorrhage also.
Postpartum hemorrhage. We said about postpartum hemorrhage, no? Life-threatening bleeding that she would have.
We
Right?
can
That is what you're trying to say.
we can tell her that your baby's head is stuck inside the passage of the delivery. Ideally, we
Right.
should deliver the baby within 3 hours maximum. So
Yeah.
we have to take some decision to help the deliver the baby and to decrease the chances of complication regarding your baby also and regarding you also. And
All right.
regarding you, there are chances of more bleeding, more than normal, that may require more treatment and may require blood transfusion and all.
Mhm.
That's why we have to take a proper decision for health of
Correct.
better health of you and your baby.
Correct, correct. Also about the 3 hours rule. If she's already pushing, it is mentioned to you that she's pushing for 2 hours. Remember, she's a primey, she's pushing for 2 hours, and the baby's head has not rotated. You would need to help her. Okay. Yes, of course, you need to check whether she's on epidural or not. But it is mentioned to you that she's pushing. That means she's already in active phase of second stage of labor, and you need to deliver her. Okay. So, and it is she's exhausted. That is the reason. Exhaustion and prolonged second stage is the reason why you need to deliver her on an urgent basis. Okay. So you just tell her that, as we discussed, the distress of the baby, which can result in permanent damage to the baby, as well as, so the worst possible outcome, you need to tell her permanent damage, as well as sometimes really you can have there can be death of the baby. I'm really sorry to be saying this. You can have bleeding, you can have exhaustion. And what is the other thing that you can do at this stage to deliver her?
Um, we could also tell her that the baby's head is in occiput anterior position, and that's not suitable for vaginal delivery. For that reason, that's another reason that we need to do instrumental delivery.
I didn't get you. Occipital anterior is not suitable?
No, it's suitable.
Oh, I'm
It's a plate.
sorry. I thought it was occiput posterior.
Okay, yeah. So
Okay.
yes, occiput posterior as well. You need
Yes.
not say it's not suitable, but that could have been the reason for delay. So even occiput posterior can deliver, but it will usually have delay in second stage. So yes, so this is what is important. Know what the station is. Okay, so do not confuse. You have to be very sure what the task is. Okay, so do not confuse posterior, anterior. If that happens, then you would really, unnecessarily you would basically lose your points there. Okay, so you need to tell her about the option of cesarean. That's important because it's not like instrumentation is the only answer to the question, to the problem that we are facing currently. There is an option of second stage cesarean, but at this stage, when the baby is at +3, second stage cesarean would be more traumatic. Okay, you may not use the word traumatic with the patient. This is I'm telling you guys that it would be more traumatic, it would be more difficult, and it can result in complications. While your instrumentation at +3 station with left occipito-anterior is likely to be straightforward. So what you need to tell her that we can consider a cesarean section at this stage. However, that is since your baby is right down in the pelvis, the complications of a cesarean section at this stage are more, okay, and we do expect to have a straightforward instrumental delivery, okay, and that is why you favor instrumentation at this stage. Okay, so that is what you need to tell her. You need to tell her what are the pros and cons with the worst possible outcome. Please don't hesitate to tell her the possibility of maternal or fetal death. Okay, you cannot tell her that you can die, but you can say that if this happens, it can be life threatening. Important to say the word life threatening. Life threatening bleeding, life threatening hemorrhage. It's important. Okay, it is important to tell her that the baby can suffer damage, can even die in the womb. Okay, in a very sensitive manner, say that I'm sorry to be saying this. Okay, so it's very important to say these lines in your tasks. Okay, now give her the option of cesarean section and tell her why not cesarean at this stage. Okay, and then ask her. So now, what is it that you think? Okay, what are your thoughts? Once you have told her everything and the problems associated, she is likely to understand. She's likely to say okay to you. And once you know that the patient is saying okay, if you think that the patient is being stubborn, is refusing the line of treatment that you propose to her, you know that there is something that you're missing. Okay, typically in the tasks, they will not have a patient who is just unnecessarily stubborn. And see, for example, in this case, if you do not ask her what is it about forceps delivery that she's concerned about, she may tell you something like, my friend had a forceps delivery and she had a tear. That is why I don't want a forceps. So you need to tell her that every circumstance or every individual is different. The circumstances that your friend was in may not be the same as yours. And it appears from examination that this is likely to be a straightforward forceps delivery. This is very important to first reassure and say that usually nothing happens. Usually you can expect to have a straightforward delivery. Okay. Similarly, when you're doing your maternal medicine tasks, you start whenever, particularly when those medical disorders are not something that you would you would think is kind of dangerous or risky for pregnancy. You say that generally women in situation like yours can have a straightforward pregnancy and delivery. Okay, however, there are certain things that you would need to know and then enumerate the problems. Similarly, here as well, we could expect a straightforward forceps or a vacuum delivery. However, there are these problems. Okay, so that is how you say. Whenever you're saying, do not just paint a dirty picture of your forceps delivery by saying, okay, forceps delivery can cause trauma, can cause lacerations, can cause bleeding, blah blah blah. No, generally it is straightforward. This is rare. This is less common. This is very rare. Using these terms is important because you need to portray the real picture to the patient. That's important. All right. So that was about a simulated patient task. Okay. Now let's move on to structured discussions. Okay. This is how your structured discussion would look. Now, this is the body of the task says that you are the ST5 in the antenatal clinic, the consultant who is also your examiner. So basically, you're talking to the consultant there, wants to discuss a case with you. Somebody at 14 weeks of gestation, diagnosed with ulcerative colitis, has come for booking and she's currently on infliximab. She has undergone a proctocolectomy with ilioanal pouch 2 years ago, and which after which she's not having active symptoms. So what are you going to do? So basically, this is the situation that is given to you, and the task is to answer the examiner's questions. Here, they have not mentioned what the examiner is going to ask. Sometimes they would tell you in the task that the task is to discuss the management with the examiner. Okay. So here they have not mentioned anything of that sort. They have just said answer the examiner's questions. But you know that you're going to be asked about the management from the domains. If you look at the domains, you know that there is information gathering. So one of the questions that you can expect in such a situation is, what further information do you want to gather from this patient? Almost always, particularly so when there is information gathering. Even if they just start with how will you manage this patient, okay, you still have to say a few points in history. And if information gathering is a separate domain, you have to start the management with history, examination, investigations, and management. So they may not ask you specifically what further information, but you have paid attention to the fact that there was information gathering as one of the domains, and that is why you are trying to fetch your marks in that particular domain. So that is why this is particularly important in a structured discussion, because in a simulated patient task, yes, you will definitely ask history. You may forget to do it in a structured discussion if the examiner's first question is what are the management options. But there is information gathering, so your management or even the question that is put to you, it may be what information. You start with history, and this is another mistake. Typical mistakes. Just remember what I'm telling you right now are the typical mistakes that candidates do. All right. So another mistake that they would do is when what further information is asked or the management is asked, when there is information gathering is the domain, they would just say the history. Information gathering is not only history. Very, very important for you to note. Information gathering means history, examination, investigations. Okay? History, examination, investigation. Three things would come under information gathering. There would be situations where examination and investigations are not important, particularly when you are seeing a patient for the first time in pregnancy and she doesn't have any problem, or maybe she has problems where investigations are already done. Okay? You don't have to say investigations, but when there is nothing given, you say history. If you want to examine, if your examination is going to add to your management or the plan that you're going to make, then examination, otherwise not needed, not in all cases. Or if you want to look at a specific thing in the examination, like for example, there is a very young girl who's come to you with pregnancy and you're thinking about STIs in her because she's young. That itself is a risk factor for STI. Less than 25, sexually active is a risk factor for STI, and you need to screen them. So say there is somebody who's come to you less than 25, she's pregnant and she's come for booking. At booking, you don't need to examine her thoroughly. Maybe you can just take her pulse and blood pressure and check her overall weight and all those things. That's fine. But you don't really need to examine thoroughly as such. But you could be wanting to examine her maybe for sexually transmitted infections that she may be having. A swab you may need to send, particularly when she tells you that she's never had an STI screening done. Okay, so if you need specific things, then yes, you say that I would like to examine that particular patient for this particular thing. Okay, another important mistake done by candidates is that they say examination and that is it. Whenever you say examination, you need to say examination in the presence of chaperone with consent. This is very important for you to note. Please do not just say, I would like to examine the patient. No. You say, I would like to examine in the presence of chaperone with consent. Very, very, very important to note. And make it a habit. Practice this way. These points you have to incorporate while practicing, otherwise it is difficult. Without practice, part 3 cannot be done. As simple as that. Okay, so you need to incorporate these points in because it is practically not possible to manage or make the entire plan in 10 minutes just like that. So you need to be perfect at it. You need to practice it so thoroughly. Okay, so that is what it is. Then, okay, for a lot of candidates were asking about this assessment of training and what, when to do, when not to do, etc., etc. So assessment of training can be done after part 1, after part 2, but it is mandatory to be done before part 3. The last date for assessment of training for November exam was 10th of July. I hope all of you have done your assessment of training or submitted your assessment of training. It takes at least a month for them to revert. Okay, so what you need is basically your account number, that the RCOG account number. You need the medical registration number for whichever medical council that you belong to. You need your internship and pre-registration certificate, medical registration certificate, and the certificates or letters confirming each post. Okay, and this you would need to get signed from your dean or from the from your where you're employed, or even from a member of or a fellow or a member of the college. You can get it signed. All right. So this is just in, and remember, when you're submitting your assessment of training, you need 4 years experience in obstetrics and gynecology in the, and this must include at least 2 years in this specialty within the 4 years preceding the candidate's initial assessment of training. That means if you are submitting the assessment of training now this year 25, it would be fine if you have the 4 years experience in OBG, say from 20, 21, 22, 23. So at least 2 of those years should be in the past 4 years. Okay, so this is about assessment of training. For November exam, the last date is in July. For May exam, the last date is in Jan. You can do it anytime before that as well. Okay, so if you have just passed part 2 also, you can do. All right, earlier it was mandatory before part 2 exam, and now it is mandatory before part 3 exam. So if you've not done, those of you who have just answered part 2 and have not done it would need to do it before attempting part 3 exam. Okay. These are certain important dates you all must be aware of. So you have your booking around 28th of August. Second booking window, second booking window opens at 28th of August. Okay, and it closes on 1st of September. So this is a crucial time for all of you. okay, for booking the exam, because the seats get booked very quickly. So you need to be seated on the computer with a good Wi-Fi connection and have your booking done. Okay, so this is for the UK, non-UK candidates, and priority booking usually is for UK candidates. All right, so that's about it. Okay, now these are a few tips and tricks which we have. Most of the tips and tricks we have discussed already. There is another detailed video on tips and tricks of MRCOG Part 3, which is there on the YouTube channel. I can put it across on the group as well. But a few important things when you start practicing, what is it that you need to understand? When you start, now that you're starting to practice, most of you are new. So if you are starting to practice your tasks, what is it that you need to know? You need to know that your simulated patient task will give, or any task for that matter, will have a 2-minute reading time. What to do in that reading time? It will differ from task to task, but for all the simulated patient tasks, I would just say read the task, check what domains, know the task, situational awareness. Like in this case, somebody said it thought it was LOP and it was actually LOA. So that should not happen. So what is important? Reread the task in the 2 minutes time. 2 minutes is a long time for you to read the task. You need not just in the 2 minutes time get flustered and, oh God, I have not read this topic. Oh God, what am I going to do? Okay. No, just be calm, read what is given to you. Imagine it's not like when you go to your clinic as a gynecologist or as an obstetrician, when you go to your clinic, it is not possible that you never get a patient with some condition which you have never read. You will get. You still take history. You talk nicely to your patient. You examine her. You try to think what could be the problem with the patient. All of this you do normally. Same thing has to happen in the exam. Okay, and it is not possible to read everything before exam. Remember that. So you need to have an open mind and think of the possibilities that the patient could be having, that the condition may be. Okay, so that is why it is important in the 2 minutes time to understand the task. A lot of mentors and a lot of people tell you that you in the 2 minutes time write down what you're going to say, write this down, write that down. Yes, yeah, even when I was doing my exam, I was also practicing in that manner. But ultimately, in the exam, the only thing that works is just reading the task. Just read and understand, grasp the tasking. That is more important. Okay. Then after that, introduction. Okay, how a simulated task goes. Okay, we already discussed this. First is your opening statement to the patient. If the patient is in a difficult situation, then you acknowledge that she is in a difficult situation, like in labor. You're going to do it quickly. The introduction. You say, "I'm one of the doctors. Am I talking to so and so? I can see that you are having a lot of pain, or is it? Are you comfortable to talk?" Your intro can be a little different for labor tasks. Your intro can be a little different for patients where it is mentioned to you that she's been vomiting or she's been breathless or she's having some pain and she's in excruciating pain. If that is given, then your introduction can be different. But most of your tasks would be patients coming to you for with a particular condition, they are comfortable, most of them. Okay. Say, for example, a patient comes to you in pregnancy with sickle cell anemia. Otherwise, she doesn't have a problem. She's just here to discuss the condition. So there you can have your own set introduction. So have a set introduction for all tasks. Like you can say, "Hi, I am Dr. Ankita. I'm one of the doctors here. May I confirm your name, please?" Okay, she will confirm her name. Then you say that I believe you are here as I can see a GP letter with you. I've gone through the GP letter. I'm aware of your situation. Is it okay if I ask you a couple of questions? Now, why is this important? Okay, your task will have the introduction confirming identity definitely is important. After that, what is important is for you to approach the task. Now they could be coming with a condition just like that, or they would be coming with referred from midwife, or they would be coming with a GP letter. Sometimes a lot of things are written in the task, like this patient was diagnosed with sickle cell anemia at the age of so and so. Then she had blood transfusions. Then she was started on this medicine. Then she visited her GP last at this date, and now she's pregnant, and now she's come to you. If everything of this sort is written in the task, you're not going to say everything in the station and waste your time. Say, I believe you were diagnosed with sickle cell anemia at this age. You had gone to the GP at this stage. You had received so many blood pints in the past. No, that is why have a set way of asking or putting forth the situation. Say that I have gone through the GP letter. I'm aware of your situation. That tells the examiner that you have checked that she has the GP letter with her. Okay, I'm aware of your situation. Is it okay if I ask you a couple of questions? That is taking permission to proceed. So you are covering everything. Okay. Setting agenda. So acknowledge the task at hand. Setting agenda. A lot of people say that you have to set agenda in the beginning. That depends on what the task is about. If it is clearly given to you that she's come to you to discuss the management of sickle cell anemia and pregnancy, then you say that don't worry, is it okay if I ask you a couple of questions? After that, we could discuss the management plan. But if it is not mentioned to you what she's come here for, you cannot set your own agenda. That is why we tell our students not to set agenda unless it is specified. Refrain from setting an agenda unless it is specified, because the agenda is based on what the patient wants to know. It is based, even particularly in a teaching task, agenda is not what you set. Agenda is what the colleague wants to know. Like, for example, if your colleague wants to know about forceps delivery, and then you tell her, okay, I'm going to tell you about indications, contraindications, application, complications of forceps delivery. Your task, the task that is assessed, is not assessing you at all for complications. It is just assessing you for application. Then by saying all the complications, you are wasting your own time. That is what you need to realize. So you have to ask your colleague there, what is it about forceps delivery that you want to learn today? So the agenda is set by the colleague. Okay. So this is simple. Um, you could say this is just common sense. Okay. You need to be smart in the task. You need to know what exactly the task is about. The task is about assessing you for a particular set of information that you're going to say in the task. And if it is a teaching task, remember forceps delivery can go for a lecture over an hour. It can be a 1 hour long lecture also. Now you have to cover it in 10 minutes. So you really need to know what exactly you are supposed to say in the 10 minutes time, right? So you need to ask the colleague that in a teaching task, ask your colleague. Okay, that's important. So setting agenda depends on whether it is clear what the agenda is. If it is not, ask your patient. So what is it that you are here for? Okay. So then open question. Always when say she's here for a discussion of the medical condition, sickle cell anemia, for example, ask an open question. So tell me more about your condition. That's an open question. Don't ask specific small questions that wastes time. Okay. Tell me more about your condition. The role player is likely to tell you everything she knows about the condition. Okay. So the open question. Start with questions that are relevant to the topic. Okay. So for example, there is exposure to chicken pox is the station. Somebody is exposed to chicken pox. She's pregnant and she's come to you because she's concerned now for chicken pox. First questions that you're going to ask is obviously going to be about the exposure. Don't ask her in the beginning, okay, you're pregnant. I can see you're pregnant so and so weeks pregnancy. And do you have any medical diseases? That is going to be irrelevant to start with. It is a relevant question for your station, but not to start with. You start with what she's come here for, calm her down, ask her about the exposure, ask her about the episode, because that is what she's expecting you to do, isn't it? So start with questions that are related to the topic concerned. All right. Then other relevant questions, like I told you, you need to ask about medical diseases, allergies. These are important questions. So other relevant questions about the pregnancy also you need to ask. At the end of the history, you can always say, thank you for that information. Is there anything specific you would like to know? Because at the end of history, if you do this, if you practice in such a manner that you ask this question, is there anything specific that's on your mind? Is there specific? She's likely to tell you things that she has not told you and you may have missed in history. And at the same time, she's going to tell you what exactly she wants to know about the condition. She may be interested in knowing transmission of sickle cell anemia to the baby. She may not be interested in anything else. So if you don't address the concern and you tell her everything about sickle cell anemia, you may not score in your task. So that is important. So at the end of history, ask her, or in the beginning, you can ask her. If you know already what the task is, what the situation is, you can ask in the beginning. Or if you don't know, and from your history you have gathered what the condition is, then you ask in the end. All right. So that is how you need to be smart in planning your tasks. Okay. Then you go through the management plan with her and do not forget to give her some written information. Okay. PIL, patient information leaflets that we offer to the patient, right? So you need to say that, and we tell our candidates to say it somewhere in the middle of the task. Do not keep it at the end because a lot of candidates will say PIL towards the end of the task and then they will run out of time because the buzzer would ring and it would already be 10 minutes and they have already run out and they have not said PIL at all. That's not right. PIL is a very important written information that you offer to the patient. Like for example, she's come to you for sickle cell anemia in pregnancy. It is important for you to tell her that I would be giving you written information about sickle cell anemia. Okay. Do that somewhere in the middle of the task. Do not do it at the end. You will run out of time. It is okay if you skip some points in the end of the task where you are discussing the postnatal care, etc. It is fine. It may not be fine to not discuss or not offer written information. So say it somewhere in the middle of the task when you are saying all the complications that you can have in pregnancy because of sickle cell anemia. You say that I can see that I've given you a lot of information. Don't worry, I'll give you some written information in the end. That is, if you say somewhere in the middle of the task, you have got that particular point. Okay, the examiner will realize that you have said it and will mark it in the answer key and say it aloud so that the examiner's attention is drawn to your points. Whatever important points that you remember, you need to say them aloud. Okay, like for example, aspirin is a very important safety point. Okay, saying aspirin in a case of sickle cell anemia or saying aspirin when there is previous history of preeclampsia is very important. So you just cannot say it with all the other points. Emphasize on those important points. Aspirin so that the examiner's attention is drawn to aspirin. That's how you need to be smart in doing your tasks. Information gathering, we discussed history, common related to the topic concerned, related to the pregnancy, and then the relevant history. Examination, investigation. Three things in information gathering. I particularly put it here so that you make a note of this. It's not just history. Okay. Communication is very important. We do have a full, I think, 1 hour session only on communication, which you can go through on the YouTube channel. So basically, communication is avoiding medical jargon. Make it a habit, okay, to when you're talking to your patients in your clinic, make it a habit to use words like womb, neck of the womb. Do not say cervix, do not say uterus, although the patient may be knowing what a uterus is. Most of the patients do know. But make it a habit to say womb. Make it a habit to say neck of the womb. Say an instrument is put in the womb to remove the products of pregnancy tissue. Okay, that's evacuation. So the way you describe your procedure to the patient in your clinic, do it in lay language. Make it a habit in lay language. Okay. So that's how you practice. You practice for part 3 even in your with your patients. You practice for part 3 with your friends. You practice for part 3 with your pets at home, with your children, and then look in the mirror and practice with yourself. All right. Make sure that there is empathy. Okay. Like for example, when the patient comes to you with say um a complication in the baby. Maybe she comes with some anomaly in the baby. You need to have empathy. I'm really sorry to be saying this, but the baby has this. That empathy should show. The tone should vary. Should not be saying it just one tone. Your tone should vary. Okay? Lower your tone. Say that I'm really sorry. No, that's how. And when you vary the tone, the examiner doesn't find it monotonous. It captures the examiner's attention. So it's important, right? Listen to the role player and respond. Your part three station should be a conversation between you and your patient. Like your patient in the middle of history may ask you something. Oh, what is the chance that my baby may have this condition? Do not ignore and go to the next station because you have to complete history. No, you have to respond to the patient. If you don't want to do it right there, say that, don't worry, I will shortly address your concern. Just one sentence, enough. And then you proceed with your, is it okay if I ask you some more questions? Proceed with your history and then come back to her concern that she asked. Okay, so that is how it is. Sensitive issues to be acknowledged, like when you say something like multiple partners, okay, you need to signpost. So say that don't mind me asking, did you have multiple other partners in the past? Okay, so other sexual partners in the past. That is how you should say. Okay, so that's important. Then information has to be given in chunks, particularly in a station like this, like maternal medicine, sickle cell, say for example. You have to tell her information in bits. Don't just go like an express train from beginning to end because you have to finish in 10 minutes. No. You say that, okay, so this is your condition. Because of sickle cell anemia, you may have risk of miscarriage, risk of bleeding in pregnancy, clot formation, high blood pressure, anemia, and complications of the condition sickle cell anemia, which is this. You're given the full information or the complications of sickle cell anemia. After that, say, am I clear so far? That is the chunk of information. So one bit of information on what happens in pregnancy with sickle cell anemia. The next bit of information would be what is the management. So your management would be in a team of doctors, and you would have more frequent visits. We would be offering you aspirin from 12 weeks of pregnancy. We would be offering antibiotics because it is required for sickle cell anemia. Vaccination would be looked into, and your investigations would be done. That is another chunk of information for management. Okay, about your delivery, another set of information. So after every chunk of information, pause and say, am I clear? Okay, do not say, do you understand, are you clear? No, am I clear to you? Okay, am I clear so far? All right, so that is how you would do. It should be non-paternalistic. You should not tell her that this is what you need to do. You should be saying that this is what is the plan, this is the problem, and this is why this is the plan. You should not sound like you are imposing your decision on her. Like, for example, if your NIPT or your amniocentesis shows Down syndrome in the baby, now you want to talk about termination of pregnancy. You will not say you should terminate pregnancy. Never. Never. Okay? You say in a very empathetic manner, you say that after having broken the bad news, you've told her that it is Down syndrome. You've told her what Down syndrome means. Then you tell her that women in a situation like yours do have the option of termination of pregnancy. What are your thoughts on this? So you're putting the ball in her court. You're not telling her you should terminate pregnancy. No, she may choose not to have termination. So you say the option. Okay, so that is non-paternalistic. Don't impose your thought process on her. Or if you have, say, a religious belief that you do not support pregnancy termination, you cannot tell your patient that it may be wrong, it is wrong to terminate pregnancy. No. Okay, so that is being non-paternalistic. Respect patient's autonomy. Like if this helps in your negotiation task. Whenever you tell the patient in the beginning, when like in the labor task just now that we discussed, she says, no, 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 I want a vaginal delivery normal. I don't want instrument. Okay. You calm her down. You tell her that don't worry, your wishes would be respected. Please hear me out regarding your options. Okay. So once you say that, she's not going to argue with that, right? So you already told her that, okay, don't worry, your wishes would be respected. You're not saying that I will do it for you, but you're saying it wisely, you're saying it smartly, that your wishes would be respected. That means you're going to come to that, okay, shortly. Okay. So that is respecting patient's autonomy. All right, so that's important. Now coming to safety. Again, there is a very long video on safety in YouTube. Please go see that after this session today. Confidentiality is very important. So how to be a safe ST5? So first thing that you would need to do is make sure that you ensure confidentiality. Okay. You need not say it in all stations. It is implied, but certain tasks where the patient may be hesitant to give you history. For example, in a case of rape, or in case where there are multiple partners, or she has sexually transmitted infections, you need to ask her detailed sexual history. She may not be open about her personal history, right? So you need to ensure confidentiality in such stations. Say that, don't worry, everything that we discuss here would remain between you and me. That is how you start your task in such cases. Like a young teenager comes to you for a termination of pregnancy. Please tell her that everything will remain confidential, okay? Unless her safety is at stake. For example, unless you think she's a rape victim, then you need to involve your safeguarding by breaching confidentiality because she's a rape victim. Okay, so unless her safety is at stake, you would make sure that everything remains between you and me. Okay. Examination in the presence of a chaperone with consent is a safety point. We have already discussed this. Safe management plan. Like in this case, the instrumental delivery. If she just because the patient says, I want to have vaginal delivery, let's wait for 1 more hour. You're not going to wait. So the management plan that you make is going to be safe for the patient. That is what it means. Involvement of relevant specialties, like when MDT is required, multidisciplinary approach is required. You say that multidisciplinary team approach would be required. When fetal medicine specialist is required, you say that fetal medicine expert would be there. When an oncosurgeon is required, you say that oncosurgeon or cancer specialist surgeon would be there. So saying all this is safety. Okay. Also, it is communication with colleague in a structured discussion, particularly consultant input. Whenever there is a situation of say massive major PPH, if you don't say consultant, you're going to lose. Okay, because you have to involve consultant in such a situation. Uh, these things. There are very few interventions or medicines that we offer in pregnancy. In pregnancy, we do not offer medicine. So every pregnant patient that comes to you, think in your mind whether aspirin is indicated, whether low molecular weight heparin is indicated. If it is indicated and you miss to say aspirin and low molecular weight heparin in your task, that would result in, if you miss to say aspirin, can result in failure because that's a very important point. All right. So that's how. Involvement of counselors, support groups, important. Okay. Whenever there is a patient who's come to you with pregnancy with a chronic problem, disease, medical disease, you say counselors, support groups. Patient comes pregnancy with Down syndrome in the baby, support groups. Patient comes with cancer, support groups for cancer. If you don't say that, that's a major safety point because that is uh, paying attention to the patient's mental health. So that's why it is important. Okay, red flags, like you do a procedure. For example, you say you do cone biopsy or LETS procedure, and you tell her that you're now talking about the procedure to the patient. If you miss to tell her to come back if there is foul smelling discharge, if there is bleeding, if there is fever, because there could be infection in that area. If you miss to tell her that, that is against patient safety. You have not given the patient safe information. So these are red flags. So this is how you need to understand patient safety. 24-hour contact, like you're saying, now you're discharging the patient who's received methotrexate for ectopic pregnancy medical management, and you do not tell her that in case red flags also you have to tell her that in case she has pain in the tummy, etc., you come back at the earliest. You give her a 24-hour contact. That's important. That's a safety point. Okay. Uh, Clinical governance. Clinical governance, there are 5Ds. There is DVT prophylaxis, there is DETICS, there is discussion, that is feedback, okay? Debrief, duty of candor, okay? So these 5 Ds, DVT prophylaxis would not be in clinical governance, but we remember the 5 Ds that are involved. Datics, if you all must be knowing, there are certain in clinical governance, if you've done in part 2, you need to do incident reporting if there is some complication. You need to do incident reporting if there is some mismanagement that is suspected. If you have missed a dose or if you have missed some medicine to be given to the patient, you have to do incident reporting. That is DETICS. The form is called DETICS. Okay. So if that is missed, then so that has to be done. That is an important safety point. Discuss is feedback to the colleague. If there is a complication because of laparoscopy that a colleague has done, you need to say that there would be a session on feedback to the colleague. If the colleague is a junior, not you're not going to give feedback to a senior. Your colleague is a junior, feedback. Okay, so debrief is talking to the patient about the complications that happened, about her, uh, about what happened to her during the surgery, what happened to her during the management of PPH, etc. That is debriefing a patient. And duty of candor is being honest with the patient. You have to tell the patient the facts. You do not have. You should not be trying to misconstrue the facts and tell her some, things that did not happen just to save your skin. Okay, so that should not happen. So duty of candor is important. So these are the 5 Ds of clinical governance. All right, so structured discussions, as we have discussed this already, understand the scenario, check domains. What is important in the structured discussion? Note where you are. Like it may be given to you, you are in the antenatal ward, you are in the labor ward. That may be mentioned to you. It is important because your management may depend on that. Note the time of the day. Sometimes, like there was a station on twin pregnancy who's come with TTTS at out of duty hours. I mean, out of the routine hours, odd hours at 6 p.m. in the evening, where most of the fetal medicine specialists would be going home. So you know that it is 6 p.m. So they may not be available. So you may need to either call them if it is urgent or do the scan necessary the next day. So that situational awareness is important. Okay, so that's important. If information gathering is assessed, history, examination, investigations. In structured discussion, do not forget, this is the third time I'm reiterating because despite multiple such, me telling so many times, the repeated mistake that is done in structured discussions is this, that information gathering when asked, only history is said. Examination, investigation is forgotten. All right, so that is what an answer to the point. Do not, for example, if there is a station which starts with what are the complications of say malaria in pregnancy, there was a recall in November. What are the complications of malaria in pregnancy? Candidates start about complication, then they go to management, then they could tell about treatment and everything. But I have not asked treatment, I have not asked management, I've asked specifically complications. So stick to the point. That is important. All right. So in a structured discussion, if a question is not clear to you, you can ask the examiner politely, please could you rephrase the question for me? Or please could you repeat the question for me? You can ask. But do not just simply answer something because you may think that it is not right to ask the question, ask for the question again. So that is why it's important for you to make sure that you have understood the question. All right. Okay, so with that, we will wind up. We were just discussing overview of part 3 exam. Detailed videos for each of the domains, etc., would be there in the YouTube channel. I could post on the group as well. We would also have frequent, subsequently, we could have free sessions on task discussions, which I didn't want to do today because it would be too much for you to gather. This is a Sunday evening. Just consider this as a warm-up session. All right. So any questions that any of you has, please you can ask now, or you can put it in the group. All right.
Ma'am,
Yeah.
yeah. Can I ask?
Yes.
Ma'am, basically part 2 paper is very hard. you must be knowing from other student
Yeah.
also. We are not sure regarding the result, but if luckily get pass, is that 3 months is sufficient for appearing for November part 3?
Yeah,
Because
provided you
so
give it time to
okay,
practice. You have to practice every day. Like even if you are
okay,
busy with your clinics, with your work, practice every day in the clinic. Okay?
okay,
Practice every day with your friend, with a role, with somebody that you can have from the groups, say study partner that you have. Okay? Do it every day. Keep in touch with your subject every day, something or the other. Then it is possible. And it is better if you do it after part two because the theory you have already done recently.
yeah, yeah, ma'am.
Okay?
That's why, na, because all things different.
Yes. Yes.
One more thing, ma'am. This group is our free group, no? This one.
Yeah. Yes.
And
This.
whom to inquire regarding the Excel course and all, ma'am?
You could message me. You can message on the group also. Somebody or the other
Okay.
would discuss. Or you can message
Okay.
me. Or you can message Dr. Uma. We also have a helpline number that also you can contact. But it's fine if you can message one of us also.
Okay, ma'am.
Okay?
Okay. After result only, we'll decide, yeah, ma'am.
Yeah, all the best
Yeah.
for all of you who have answered. I'm hoping you would all pass part two.
After
Okay?
part one, we
Hoping
are
to see you on
confident,
the other
ma'am.
side.
Yeah, ma'am.
Yeah.
Thank you, ma'am.
All right.
Thank
All right.
you.
Bye. Thank you for patient listening. Any questions, please feel free to put on the group.
Yeah, ma'am. Thank you.
Yeah.
I'm following
Yeah.
you on YouTube, ma'am.
Okay. Yeah.
Yeah, thank you, ma'am.
Remember.